So Miss Victoria Selby is a senior neuromuscular respiratory physiotherapist from Great Ormond Street Children's Hospital, London. So she'll be sharing her experience in respiratory therapy in neuromuscular disease. Over to you, Miss Victoria.
Myself, and then I'll start again. Thank you so much for inviting me to join your sessions, and for even asking me to speak. So as you said, I'm a cardiorespiratory physiotherapist with a neuromuscular history and background for the last 20 years. So I've just been asked to do a couple of case studies of how we would do things over in London at Gosh with a couple of our neuromuscular caseloads regarding spinal surgery. So the first one, we're going to whiz through, interrupt at any time and ask questions and make it as interactive as we can, because I think that's the best way that we all learn. So this young boy has rigid spinal muscular dystrophy, diagnosis with the SEPN1 gene. He was seen at Gosh since the age of 2 years and 10 months. He had regular reviews. At the age of 7 years, he was put on BiPAP following a sleep study, and his pressures were 11/4. He was pretty non-compliant with most of his physios, but he had very good compliance with his NIV. But we had the joys of COVID and the family isolated during the COVID because of pandemic and keeping safe. Oh gosh, I've skipped a couple of. So at about 14.5 years, just after COVID, it was January 2022, or when we were seeing people again, or we were seeing people, but they were happy to come in. We had this referral. His diagnosis, rigid spinal muscular dystrophy, severe scoliosis, attended mainstream school with an EHCP in place, but he's not following through with his program. He had a significant growth spurt, and his scoliosis had been made worse. He didn't have spinal bracing and wanted a review of his spinal surgery. They were keen for a review as quickly as possible, and his younger sibling also had the same condition. So he was referred for spinal surgery on the 18th of February, at which point he could walk about 3 minutes. He didn't have any back pain. He had a Cobb angle of about 60 degrees, and he was offered surgery, or a candidate for surgery. However, he was 30 kilos and 158 centimeters tall. So he wasn't classed as being fit for surgery. Had a peg inserted, and he was referred to me to help with optimize his lung health. This took, with his weight, we saw him regularly. He wasn't gaining weight particularly well. We were trying to optimize his respiratory function, his weight, and bones for surgery, he was offered surgery on the 7th of December 23, and he had the spinal surgery on the 13th of February. It was a posterior spinal fusion. Oh, I got that the wrong way around. Posterior spinal fusion. Took 6 hours, 1 minute, and it was from T4 to L4. So his chest physio journey through this, he was a little bit non-compliant with most physio, which suggests that, I know in the family, that they were non-compliant with what we offered them. They were initially taught a lung volume recruitment bag technique to help improve cough strength and lung volume. Had poor compliance. He had better compliance with a face mask, and then a mouthpiece, and then a face mask. So we tried lots of different options. We saw this child regularly every 6 months or so. We had lots of education with him, but compliance remained poor because he didn't see the point. He didn't have any chest infections. He didn't need any antibiotics. He didn't see why he should use it and have to cough. So there was lots of discussion about introducing the cough assist around the time of spinal surgery, pre-op and post-op, just to see if we could help optimize his chest health. A couple of weeks, or a few weeks before surgery, he had a phone call from Dad, who was slightly panicked. And he said his child had a chest infection. He was unable to clear secretions. He hadn't been using the LVR bag, the lung volume recruitment bag. He didn't have any suction in, and he was in a bit of a panic because his child was poorly and he couldn't help him get better. So he did agree to use the lung volume recruitment bag, and we made him an appointment to discuss and talk about the cough assist, which we'd already discussed and introduced the idea before, so it wasn't completely unheard of. So we did. So we issued him a cough assist, and I think the fact that the child had a chest infection made the family more aware of how serious chest health can be, and chest infections. It's not nice when your child can't get their breath or cough up their secretions, and becoming more and more fatigued and tired, and then less ability to cough. So they used the cough assist and optimized his chest health prior to his spinal fusion, which was good. So he used it all the way up to the spinal fusion, 2 or 3 times a day, as we asked. And so when it came to the day of the spinal surgery, he was in good respiratory health. He needed 1 overnight stay in PICU following the operation, but he was only on his home oxygen, home NIV. He wasn't. Hello, sorry.
Please go ahead. Sorry.
He didn't need intubating for the night. He was on his BiPAP, and he was transferred to the ward the following day. So day 2 to 5 post-op, he had 3 times a day chest physio, which consisted of 3% saline nebs, cough assist, and oral suctioning. So this was also done overnight via the on-call physio. So split over 8 hours or 6 hours sessions. Between days 6 and 8, the family were more on board. So physios did the morning and afternoon session. The family did the evening session. By day 9, he wasn't needing the 3% salines anymore to help clear his secretions, but he had 3% in the morning and 0.9% saline with the other 2 sessions. On day 10, post-op, physio just did the morning sessions, and by day 11, he was discharged from respiratory physio with a bi-daily cough assist plan with oral suctioning, with a 0.9% neb in the morning and a 3% neb in the evening or afternoon. During the whole time, he was unable to complete his lung volume, lung function tests because of compliance, but he could complete a peak cough low. And in 2020, so pre-surgery, it was 170 litres per minute, and post it was 203. Post in 2023, so it was 176 litres per minute. So I think we didn't lose anything. We got some more compliance. We were feeling a bit pleased with ourselves and pleased with him, and the family were now looking after chest health and doing some rehab with his chest post-op. And I think we were in a good place when he was discharged. Following discharge, he had really good compliance for a while, and then it reduced. And it's still quite reduced. He probably does it about 2 or 3 times a week, which is better than nothing. But he wants to go to uni at some point, and we'll have to transfer him to adult services, which we're very lucky in our children's world in Great Ormond Street that we have the time and we can keep seeing patients when they go to adult services. I'm not sure of their procedures, and he was pleased he kept the weight on, and he was pleased that he had the surgery. So I think it was an uphill battle trying to get the compliance going and the interventions in, but we did, and I think we got him through the period where he could have struggled, and what will happen in the future we don't know. And that was a bit of a whistle-stop tour of him. But this is his, because of his condition, his rigid spine. He has the C-spine scoliosis, but it's also a kyphosis with the hip flexion. So actually pre-surgery, he was his diaphragm was very compromised. If he was sitting in his chair, a lot of his problem is he was sitting so far forward that he had neck extension. So when they straightened his spine, we had to straighten it so that his head could also still be looking forwards. So that was his pre-op, and then his post-op. Sorry, I flipped the view for some reason. So the first one is his lateral sitting position, and then hits AP on the other side. So I think it's an interesting case. The slight frustrating thing is his brother was also referred, but his brother's progressed a lot further, and I think current issues with his brother is his spine's too far gone, his too far forward, and his neck is protruding so much that his cervical vertebrae coming forward and displaced his trachea to the away from midline. So trachea and intubation, everything's quite difficult. But the brother is quite compliant with his cough assist and everything else because we introduced him early as well with his cough assist. But unfortunately, it looks like he's going for a second opinion to see whether spinal surgery is even possible for him, which is a little bit of a shame after his brother's done quite so well with his spinal surgery in the end. So that's really all I had to say about him. I don't know if anybody had any thoughts or questions about what we could have done better or what you would do in similar situations or things like that. Or not?
Yeah, thank you for sharing the story of those brothers. And it's quite unfortunate to have heard about this younger sibling not being able to undergo surgery. Did we have any questions or comments? I think. So this is Mrs. Jaya. She's a respiratory therapist. She's actually at the NHS. So we can't hear you. You're still not audible, sorry. Do you want to type it in the chat?
I was just about to ask how early was the early mobilization started in the ITU for the patient?
The mobilization post-spinal surgery?
Yeah.
Yeah. So once they go to PICU for a day, stabilize, and they go to the ward, and then they're often up in their chair within day 2, maybe day 3. We at least sit them over the edge of the bed,
Okay,
and then we go up. They're discharged as fairly mobile within 10 days normally, back to normal. So we do gradually sit in the chair for an hour, half an hour, twice a day, then an hour, until they're back to their usual routine.
Yeah. Was there any modifications on the chair after surgery? Like, was it a surrender chair or a recliner, or was that anything considered while?
Miss Victoria, your mic is off.
Sorry. Because he wasn't braced, because he had a molded wheelchair. So we have the chairs that you can then remold post-surgery towards them. Yeah. Okay. If the children are in braces, like spinal braces, TLSOs, they tend not to always have such molded chairs because the brace will do the work, and then you just have like supports, thoracic supports and things like that. So a lot of it depends on what their pre-op status
and in
is.
terms of airway clearance, the cough assist pressure, was it the same that was pre-op, or was there's no cough assist used pre-op?
So he had cough assist pre-op. We had discussed a lot of the cough. So he started on the lung volume recruitment bag, and we started discussing the cough assist pre-op. But they were still a bit not sure about it because they thought he was fine. But then when he got his chest infection, it's probably about 4 to 6 weeks before his surgery, they were like, oh, we need. So he had a good 6 weeks of his cough assist before the surgery, and we got did a bit of nebs, and because he had the chest infection, so we started him on 3% nebs, cough assist, and a Yanker suction to get things clear for surgery. So I think the chest infection was a little bit of a blessing in disguise that he then wanted the cough assist. I think you're on mute.
You're on mute.
Unless she's translating.
You're still on. Okay.
Yeah, thank you. Yeah, I'm good. I'm good. Yeah, thank you for the answers. Yeah.
Yeah, thank you, Miss Victoria. So I'm going to ask Dr. Murli, uh, who is a spine surgeon, and his interest in physics actually sort of, I think, helped him understand biomechanics better, and also because he's a spine surgeon, it's interesting how you found your calling with biomechanics and physics and spine surgery. So if you have any questions about the previous talk and you want to share your experiences, please go ahead.
That was a great presentation, Ms. Victoria. Hello everybody, I'm Murli, and thanks for the sweet introduction. Um, Definitely, yes, the beautiful job done by the spine surgeons and an amazing post-op recovery that we saw with the first kid sibling, and then unfortunate that the second sibling, was not fit for surgery. Having said that, uh, see, it's all about biomechanics of spine, right? Spine is the framework of the body. Our entire human body is supported by the spine, and it's a load-bearing structure. Uh, what happens in especially with neuromuscular disorders is that the core muscles, the truncal muscles, which are responsible for giving the strength to the spine, the bones, the ligaments don't offer the strength to the spine to bear any weight. It is the muscles which give them the strength. And when these muscles go weak, obviously the spine fails. It collapses on itself. And that is what we see in these kids with neuromuscular disorders. And there's a lot of difference between what we see in, say, in adolescent idiopathic scoliosis, where the entire neuromuscular integrity is maintained, but then you have a structural curves. So you can have a very focal curve in the thoracic spine, or a focal curve in the lumbar spine, or a thoracolumbar spine, or a double curve, various combinations. In my personal experience, whatever I have seen with neuromuscular disorders, irrespective of the diagnosis, is a single universal C-shaped curve. All the kids basically they're collapsing, their rib cage, rib frame is almost abutting their pelvis. There is a pelvic obliquity which develops over a period of time, and invariably kids develop osteoporosis, and these kids are obese, uh, especially with our Indian experience. So most of the kids are obese, also struggling with osteoporosis. So in these patients, what as a spine surgeon, we are not trying to correct any biomechanic. Okay. We are not really looking into all the sagittal balance and structural balance, Cobb's angle. See, everywhere, everyone gives so much of importance to Cobb's angle, right? So, whereas here we are looking at dignity of life, we are looking at better sitting, better breathing, better nursing care, better transfer. These are the basic things, the functional goals which we look at in these kids. It was never about getting a beautiful X-ray before and after, because I'm telling this as a spine surgeon because it is so difficult for a spine surgeon to stop correcting. When we see we want a perfect X-ray post-op, and that's how we are trained. But then here to accept, okay, that whatever is the best possible correction for the given child, because beyond a level of correction, the curves itself are very rigid. They are not flexible at all. By the time the doctors, the treating doctors, decide that yes, this child should need a surgery, it's already too late. This is another experience of mine. Because we wait for the Cobb's angle, we wait for the child to really get into trouble. And by that time, the child is already obese and already having osteoporosis. Curves become so rigid that they're not flexible at all. So it's not going to be so easy that we can straighten the spine. Any extra effort, we are staring at fracture or a screw pull out. So those, I think, because we have a huge community here and all of you are dedicated your life for a cause, probably the indications over a period of time should change. That is like catch them little early, then they actually come. Okay, thereby we can give them a better quality of life. By the time they develop respiratory distress or like difficulty to breathe, I feel it's already a little late for surgery. Having said that, I'll just share my story because, honestly speaking, I wasn't willing to operate on these kids. That's how it started until Dr. Anne Agnes Matthew spoke to me, the passion in her to treat these kids. And for a surgeon like me who always think about correcting the curvature straight, making them walk, bringing them back to life with normal activities, it was very difficult for me to accept that, look, I'm correcting a curve so that a child is going to sit. This child is sitting on a wheelchair, continuing to sit on the wheelchair. So, but then after Dr. Ann persuaded, and with this experience of the number of patients that we have operated together, today I firmly believe that there is a definite role for surgery. And in fact, I'm one of the proponents of early surgery. Let us not wait until the child really develops osteoporosis or respiratory distress or a fixed curve. We know it's going to happen, and catching them early gives them better quality of care, better dignity of life, and definitely adds years to their lives. So in my experience, what we do is Dr. Ann doesn't directly refer any patient to me. I'm blessed that way. So they have the entire team who work up the child. They're taken care of. Nutrition is taken care of. Their chest physiotherapy and then the entire program for them. And by the time the child comes to me for a surgical correction, invariably they are fit. Anesthesia is a huge challenge. ICU care is a huge challenge. Surgery actually is not. Okay, the truth is, surgery in these kids are not a challenge at all. They are straightforward surgery like what we do in any other patients, but the entire care revolves around the anesthesia and the perioperative ICU management. To add to whatever Ms. Victoria had spoken about, scoliosis surgery in neuromuscular disorders, okay, they are not corrective or deformity correction surgeries at all. They are in fact rehabilitation enabling surgeries. Our surgeries are only going to enable better rehabilitation, or rather, in a holistic term, it is part of rehabilitation. Surgery for scoliosis in NMD is part of rehab for a kid and should be timed properly. And it also needs to be followed up with a very good physiotherapy and care to have the optimum results. So these are my experience, and I mean, yeah, anybody want to ask any questions, suggest feedback, I'm open.
Thank you, Dr. Murli. So from a rehab point of view, post-op care, right? So once you've operated, we go back to seeing the child, and then I think largely families have two questions. One is what about bracing at this point, and the wheelchair modifications. So we again, by the time, like you said, by the time the child comes to you, the deformities are fixed. So pelvis and spine, those changes will happen again. Especially, I think post-op bracing is a large question that people have. So if you could.
Yeah. So one of the biggest job I have more than surgery is counseling the family. Okay. So this starts even before the surgery. Almost a couple of hours of session happens multiple times. And I'm sure even though all the physicians and every caregivers have spoken to the parents want to hear it out from the surgeon. And that is how it is. So the realistic expectations, because when you talk about subjecting a child for a surgery, which is quite risky, given the situation, the parents need to know all the information, and also we have to set up the realistic expectations to them. So during this counseling, one of the commonest question they ask is about bracing. For the patients whomever I have operated, the wheelchair modification was not a major issue at all. But whereas bracing was, because the kids were not happy with bracing, they had to change the braces so often, and they were highly uncomfortable. And given the tropical country we are living in, very hot, and they want to first move away from bracing. The first question they ask is, can we, just stop using any of the brace or support? So post surgery, okay, I always recommend to use at least thoracolumbar brace, a regular brace which we give for any other child. We don't have to have a complete corset, but I do recommend to continue bracing because invariably our kids, most of the kids whom we have operated are obese. Okay, and there are no muscular strength to hold on. Placing multiple screws, in fact, I do long segment fusion, and with titanium rods alone wouldn't help because and these they can be screw pull out, or the curve still can progress because titanium is malleable as well. So some kind of a support is still recommended, but not that strict corset which they are otherwise they use. Regarding the post-op care, pain management is of paramount importance here because these kids they need very judicious pain management because overdosing is not an option for us. We have to get them out of, we have to extubate them, getting them out of the ventilator. At the same time, we also need them to cooperate for early mobilization. We believe in early mobilization, similar to whatever Ms. Victoria spoke about. The first post-op day is where we are, still just getting the child prepared mentally, psychologically, talking to the child, parents around, and all. And the second post-op day, we mobilize the kid. Okay, and that point of time, we do use bracing for the kid, and that in fact helps. It gives more confidence to the parents and the kid.
Thank you. Any other questions? If anybody's got comments.
I don't know if you can hear me, but thank you. It's nice to hear the spinal surgeon talk. So positive.
Thank you. Actually, if we can switch, I think there's a quick question for you, Miss Victoria. Would you like to take it now, or do you want to wait?
Yeah, no, what was the question?
So how would your post scoliosis surgery PT change with diagnosis? Say between a non-ambulant child who has Duchenne's versus a non-ambulant child with SMA in terms of strategies.
So I think in terms of strategies, with the SMA, they're often, let me start with the DMD. The DMD has gone through a progression of deterioration and worsening condition, and I think they find it more often difficult. They don't want the cophasis, they don't want the rehab, they're finding everything harder. But it's going to help with some pain, hopefully. But the SMAs, I think they're slightly easier sometimes to rehab because they're a lot more positive. They're doing this for sometimes a different reason. I think we often heard SMAs have the magic growing because they grow with them, whereas it's a final fusion for the DMDs. So I think I often go in a very positive way, but I think it's the families. I think SMA, they're already set up with their cophasis and their suctions and everything. So this is just a little bit of a tweak that we do rather than introduce something completely new when it comes to the respiratory side of things. From that point of view, I think a lot of our Duchenne's, if we operate on them, they're older teenagers that have a different attitude often to our SMA children. Does that make sense?
Yep, I think you answered that question. Thank you. So should we go on to our next speaker, Dr. Jayan Sampath? He's a senior pediatric orthopedic surgeon with an interest in neuromuscular disorders. Sir's got an experience of more than 25 years in the field. Dr. Jayan, do you want to share your slides?
Good evening. It's a pleasure to be here. Thank you to Dr. Ann and Dr. Vinitha for inviting me. So I have a much more structured presentation. So I think mostly therapists in the audience.
A mix, actually, sir.
Okay. So anyway, all of you will be seeing children with neuromuscular problems. Just a minute. I'm just trying to get Zoom to work.
Yes, sir.
Just a minute. I'm just going to share my screen. you're able to see my Dr. Vinitha?
Yes, sir. Yeah. Clear.
Slides are moving?
Yes, sir.
Okay. So a lot of changes for us as orthopedic surgeons because children with neuromuscular disorders are living longer with better quality of life. Naturally, their expectations are higher. And we are actually having to liaise with adult orthopedic surgeons who have a very poor understanding of neuromuscular disorders to actually transition them into adult care. In the last 25 years, things have changed a great deal. But even now, I'm seeing that a lot of these problems are not being, patients are not being referred to us at the right time. So I thought I'd go right back to the basics and talk about how, as an orthopedic surgeon, at a very basic level, I look at these problems and just give you an idea about what is the orthopedic perspective on this, because there are respiratory physicians and therapists and neurologists in the audience. So it'll be good for you to see how I look at the problem. So we basically distinguish between cerebral palsy, which is an upper motor neuron lesion, which has spasticity, etc. And all the neuromuscular disorders fall from an orthopedic standpoint into a lower motor neuron lesion. And the two types of conditions have very distinct characteristics and presentations from our point of view. So even though you will make a lot of distinctions between different types of neuromuscular disorders based on genetics and so many other things, for us, all neurological problems fall into these two basic categories because their behavior is very similar within these two categories. So lots of neuromuscular disorders, all of you are familiar with all these terms. But really, from our point of view, we want a simple system that's based on common principles and one assessment scheme for all these conditions that will help us to describe the abnormality and help us to plan treatment. So all of neuromuscular problems tend to get referred to us because of deformity. And this deforming force is on a developing musculoskeletal system. So it differs from neurological problems in adults, where there is no change in the actual skeleton or in the orientation of bones and joints. And fundamentally, it's because of muscle imbalance. And muscle imbalance happens because of weakness. And all muscle groups are weak, but some groups are weaker than others. And this is what this selectivity in muscle weakness is what causes muscle imbalance, causes deformity, contractures, joint dislocations. So all of this results from unequal weakness of different muscle groups. We also have altered line of action of muscles, which again can promote deformity. The ground reaction force is a huge factor. So once you start to walk with a bent knee and the ground reaction force goes behind your knee, everything else being equal, just the fact that the ground reaction force has gone behind your knee will start to push you down into a greater amount of crouch over time. So many of these problems just have a tendency to progress as the child gets older. And the other problem is the so-called law of magnitude. As we get bigger, we get weaker. And the biggest change happens during the pubertal growth spurt. So many of you will have noticed that children who were walking when they were 10 or 11 stop walking by the time they are 13 or 14. And this is because when a muscle increases in volume, its strength goes up 4 times, but its weight goes up 8 times. And this is just a physical law. There's nothing we can do about it. So there is a constant reduction in the power to weight ratio of children as they go through growth and they become bigger adolescents and adults. The function of the muscle is also important. And anti-gravity muscles, the hip extensors, knee extensors, and the ankle dorsiflexors and everters, which help to maintain us against gravity. These are the muscles that are more disproportionately affected by neuromuscular disorders. And we don't know the exact reason why this happens, but it does happen to be the case. So one needs to conduct a very thorough physical examination, and this is of particular relevance to therapists in the audience, but also to neurologists. So you have to look at the gait, the spine, you should look at limb length discrepancy, and look at how the child is walking, the various rockers of gait, the first rocker, the second rocker, and the third rocker. I'm not going to teach any of this today. I just want to refresh your memory. And obviously look at the child sitting in the wheelchair, whether they are comfortable, whether the spine is properly seated in the chair, look at their splints, look at shoes, patterns of wear in shoes, and also look at the wheelchair patient combination, whether it is ideal for the particular patient. And these are specialized tests we do, the Coleman block test in a child who has a cavo-varus deformity. And then we perform, these are all basic tests that we do, but I would recommend that as part of the overall assessment, that these tests and their findings should be recorded for all patients, and changes in these values over time really gives us a lot of useful information as to whether the treatment, the non-operative treatment that parents do, physiotherapy, splints, etc., whether it's having a positive impact on during as the child grows, because many of these problems tend to get worse. So this is just an illustration of doing a popliteal angle, which we commonly perform to check for hamstring length. But you have to understand that in many children with neuromuscular disorders, they have anterior pelvic tilt, which tends to artificially drag the hamstring down. So what we do is to flex the opposite hip so that the pelvic obliquity gets corrected, and then you get a true assessment of the hamstring length. And this is called the hamstring shift test. Do a modified Thomas test, check for the gracilis, and check for rectus femoris tightness, the Duncan-Ely test, and also check for bony torsion of the femur and the tibia. So these are all important physical examination that we do as orthopedic surgeons, and we encourage therapists also to do a thorough physical examination every time they see the child, and also to record the findings at least on a 6-monthly basis. So when we look at the lower limb, we look at each joint and segment in turn. We are checking for neurology, we are checking for mechanics, and for biology. So it starts off, for instance, if you have a claw toe, it starts off with weakness of the intrinsic muscles of the foot. That in turn causes hyperextension of the MTP joint and flexion of the IP joints. And over a period of time, if these deformities are left untreated, it secondarily causes dorsal displacement of the plantar fat pad and a dorsal MTP contracture. So as orthopedic surgeons, we try and correct the biology, we try and rebalance the mechanics. Obviously, the neurology is something we cannot treat, but we at least try and deal with the mechanics and the biology. So at the hip, as I said, anti-gravity muscles, the hip abductors and extensors are most commonly affected, manifesting as anterior pelvic tilt and a Trendelenburg gait. Over a period of time, if these abnormal mechanics are not addressed, it will result in a hip flexion, adduction, contracture, more commonly or more rarely an abduction, external rotation, contracture. But you don't want to leave it to a stage where a child is developing contractures. We want to try and prevent these secondary changes from happening. Femoral anteversion, again, is very common in these children because of hip abductor weakness. And if the in-toeing gait resulting from the femoral anteversion is causing a disturbance to the child's function, then we perform things like derotation femoral osteotomies. So this is another common problem, hip subluxation, because of abductor extensor weakness. They develop a flexion adduction contracture. And if the prognosis for ambulation is good in the longer term, then surgery is recommended. Surgery is also recommended in painful dislocated hips. But we want to monitor these hips with X-rays on a regular basis, 6-monthly or annual X-rays, and you want to try and prevent the subluxation if at all possible. So therapy and bracing are important aspects of prevention of hip subluxation in children with neuromuscular disorders. So even when we perform surgery, this is an example of a dislocating hip in spina bifida, and we have done a perfectly reasonable operation putting the hip back in, but then 3 years later you can see that both hips are out and muscle imbalance sometimes works against achieving an optimal outcome in the long term in children with neuromuscular problems. At the knee extensors are mostly affected, pushing them into crouch and increasing knee flexion. And then over a period of time, they develop shortening of the hamstring, an overly long extensor mechanism with patella alta and a knee flexion contracture. So typically we'd manage these at a younger age with therapy, serial casting, and then various surgeries in the more advanced stages. And even when we perform surgeries to straighten the knee, this is a 4-year-old boy who underwent a supracondylar extension osteotomy. You can see that we have deliberately extended the knee through the supracondylar region and fixed it. And 3 years later, the picture on your right shows that the extension osteotomy is completely remodeled and the child is back with a flexion contracture. So recurrence is a big problem following orthopedic surgery in young children, and we try and delay the surgery as much as possible. So this is a new treatment that we have where we use growth. We use these devices called 8 plates, and this guides the growth in the right direction. So an 11-year-old boy who had an 8 plate put in the front of the knee causes the posterior femoral growth plate to grow faster than the anterior side. And as the child grows, the deformity corrects. So as far as possible, rather than doing osteotomies, we try and use growth to achieve the correction for us. Foot and ankle is an important aspect. Almost 80% of children with neuromuscular disorders have at least some foot and ankle problem. And when you assess the foot and ankle, we recommend that you look at the individual parts of the foot, the hind foot, midfoot, and the forefoot, and assess them individually. So that's the forefoot, the midfoot, and the hindfoot. And you can see various combinations of deformities. So the forefoot could be in plantaris, midfoot could be in cavus, the hindfoot will be in equinus. So even though that foot actually looks straight, there are various deformities in the individual parts of the foot which need to be corrected, assessed and corrected individually. So you can have adductors, you can have heel varus, or combinations of problems. So typical foot and ankle deformities that we get are equinovarus, calcaneocavus, cavovarus, a rocker bottom foot, or an equinovalgus foot. I won't go into the details of these, just to give you a broad understanding of the types of problems we deal with as orthopedic surgeons. So equinovarus is because of a stronger gastrosoleus and tibialis posterior compared to the dorsiflexor everters. So even in non-walking children, a static equinovarus deformity can affect positioning of the child in the footrest. So dynamic deformities tend to happen in walkers. The tibialis posterior tends to be involved, and doing 3D gait analysis in these children with dynamic EMG is quite important as part of the assessment. So I'm not playing the videos because I didn't want it to interrupt the presentation. So typically we would do tendon transfers and flexible deformities. In rigid deformities, we will move on to doing osteotomies, and in severe or neglected problems, we have subtalar and triple arthrodesis as salvage options. So calcaneocavus deformity is something that develops in spina bifida. It's because of weakness of the gastrosoleus, and many of these children, because of an insensate foot, can develop neurotrophic heel ulcers. So diagnosis of these deformities at an early stage helps us to prevent the secondary problems such as heel ulcers, trophic ulcers in children with neuromuscular problems. So congenital vertical talus is something that happens at birth, associated with various syndromes. Bracing is very difficult, and in most children, we need to perform some kind of surgical correction. Equinovalgus deformity is another common problem that happens in children with neuromuscular problems, and it is because of weakness of the dorsiflexors causing the child to toe walk, and because of the way the subtalar joint works, the foot also tends to go into valgus. And surgery is typically performed in these children in the adolescent years. So as a summary of treatment, we release tight muscles and soft tissues. We correct the deformity either through soft tissue releases or osteotomies, and whichever muscle is functioning, we transfer it in order to correct the muscle imbalance that, as I mentioned previously, is the reason for these deformities. So we'll just look at an example of a cavevirus foot. This is quite common in children with neuropathies. They have varus of the hind foot, a high arch, and they also have supination of the forefoot. They walk with a wide-based gait. And they also, many children with these neuropathies, the foot tends to get picked up, but the hip is sometimes missed because they have silent hip dysplasia. Many of them develop neuromuscular scoliosis. Dr. Murali has already dealt with this. And they also have involvement of the upper limb, which should not be neglected. So Duchenne muscular dystrophy is the commonest muscle disease that we see. But I think today we are not talking about Duchenne. But so far as an orthopedic surgeon is concerned, orthopedic surgery, all of these muscle disorders tend to behave very similarly in terms of their orthopedic problems. So we recommend regular stretching and strengthening, nighttime splinting. In children who are not independent ambulators, they should at least spend a couple of hours a day in a standing frame. And if we are doing surgery on these children, aggressive post-op mobilization is very important as part of the treatment. So lower limb surgery has been controversial, but given the improved overall quality of life and neurological outcomes that are being achieved through better medical management, we do selective surgery on those children who have some potential for walking or at least for standing, for transfers and things like that. So I work closely with therapists, with Dr. Ann and the neurology community to try and improve the quality of life of these children through performing very carefully thought out deformity correction surgeries. So as an orthopedic surgeon, before I start any of my interventions, I'd like a diagnosis and understand the prognosis for walking and for life expectancy, assess which problem is most important, prioritize, and then do the surgery. So generally, lower extremity problems tend to happen at all levels and in all planes. So we want to define specific functional goals through targeted surgery, but accept that some problems are unfixable and others may not really need fixing. So so that's what we typically like to think of ourselves as out-of-the-box thinkers who hopefully we can be of some use to the brainy neurologists. Thank you.
Thank you, sir. Do we have any questions for Dr. Jayant?
Could I ask a question, please? Sorry.
No,
Please do. No, go ahead.
I won't get invited again. Would you operate on somebody's feet for pain management, because they're in a lot of pain, if it wasn't a risk to life to do the operation?
If there was a risk to life, or if there wasn't?
Well, if there wasn't an over risk to life, I mean, there's always the risk, but if there wasn't a big risk to life.
Absolutely. I do orthopedic surgeries even on children who have a risk to life. So, because we feel that no person should be in pain. So it's a fundamental, universally recognized human right that no human being should be in pain. They should not be in discomfort. And if there is something we can do to relieve them of so pain is the commonest reason why we operate. And pain is in my opinion, pain is an absolute indication to do something. And we try all non-surgical treatments first, but I don't think it is fair to ask anyone to just suffer through pain just because we think that there might be some risk involved. There is a risk involved in everything. So we have a very good team. We try and optimize the condition of the child, and we have a good anesthetic team, good post-op facilities. So we do fairly involved surgeries in children with neuromuscular problems. Some of them even end up in the ICU after the surgeries I do. But with modern management and with a good multidisciplinary team around me, I feel confident that we have the wherewithal, to at least make sure that they are pain-free. So I think that's a very important reason for us to operate. And many of these children have, pain in the hip because of dislocated hips, or they have foot deformities, callosities, unable to stand, walk, so many reasons. So all of them are very valid indications for surgery.
Oh, thank you.
Thank you so much.
Thank you, sir. If there are any other questions that come up, we'll take it in the end. The next speaker is Miss Mahima. She's our prosthetist and orthotist at Bangalore Baptist Hospital. So over to you, Mahima.
Thank you for the introduction, ma'am. Good evening. I'm Mahima. I'm orthotist and prosthetist at Bangalore Baptist Hospital. And today I'll be discussing about the rare cases which we have seen and how did we address it. So the first is about the congenital myasthenic syndrome, where we saw this kid and he had hyperextension of neck. And the main problem was when he walks, he's not able to see the front view. He could only see the roof. And if he tries to put his neck in the neutral position to see forward, he tends to fall completely. He loses the balance. So our main goal was how can we stabilize his balance and meanwhile make him able to see a front view. So as you could see in the picture, we have made a backpack, to say it, a custom-made orthosis where it's supporting his head and able to give a maximum support where he can see a front view. To understand the entire issue, we had to go back and learn and understand the range of motion of this kid and the center of gravity so that we don't overcorrect, but meanwhile help him to walk and as well as see the front view. So as you could see this picture with and without the brace, When he walks, he has a lumbar lordosis, he has knee flexion, and he does tip walking. And with the brace, we have seen the reduction in the lumbar lordosis, but still he was doing a tip walking. And with the brace, we could see that it helped him to see forward. We didn't overly correct. There was only a maximum range of motion which we could correct. And this really helped the kid to walk and see a front view. This was one of the rarest case we have seen. And the material which we made, we wanted to make something very lightweight. As you could see in the picture, we used 4 different material, which is of plastic, polypropylene, a foam, and an aluminum bar, where we could adjust the angle. So we made as lightweight as possible for the kit. So this is the last outcome of the orthosis, which actually looks like a backpack. And the next case is of spinal muscular atrophy type 2. And in this case, we have come to see that this kid had poor head control and a trunk control, where the maximum support was given by the parents. And we have to be very mindful that he had bony prominence, ribs and vertebra, and a pec tube. We wanted to help this kid with providing a TLSO, spinal brace, and as well as providing a head support. So we took an inspiration from Philadelphia collar, which you would usually see in ER, which acts like a traction. So again, a question, how do we work with the material? We wanted something lightweight. We didn't want a multiple orthosis. We wanted to keep the orthosis in a one piece. And we wanted to make sure that he doesn't get a pressure ulcer and prevent from further deformity, and as well as give him as much as support and stability. So as you could see in this picture, we have made a Philadelphia collar with a thermoplast material, which is very lightweight, and we made it in a way that it can act like a traction and hold the chin, as well as we have been working on the spine, and we kept in mind that he has a pec tube, and we had to be very mindful that we don't develop any pressure ulcer. So this was one more case which was challenging, and as well as an experience for us to play around with the different material and see how helpful it could be to individual kids who has poor head control and a trunk control. As you could see in this picture, in the previous one and this one, that now he's able to sit with a very minimal support from his parents, and he's actually seeing a cell phone now. And the third one, I would not say this is a rare, but most commonly neglected assessment step for Duchenne muscular dystrophy. We have seen many kids who are especially non-ambulatory, who has pelvic drop, who come with a wheelchair, and with the missing step of assessing the pelvic drop, there are many things which comes along with it. The pelvic obliquity, lateral spinal curvature, trunk leans towards the lower side, asymmetrical shoulder height. Why we have to address the pelvic in the beginning itself? For us, in a sitting position, pelvic is a foundation. And when the foundation is weak, the entire other pillars are gonna collapse sooner or later. So the kids whom we see here, they have a wheelchair. Yes, they have motorized wheelchair, they have very expensive motorized wheelchair, they ambulate, but then what is the point then where their pelvic is not addressed? And they go to school, they have to stay for 7 hours, 8 hours in the school, and imagine them sitting in this way. So I'm not saying that this is the main reason they are getting scoliosis, but this is one of the reasons where they sooner or later they develop scoliosis. So here, in our place, we do the assessment of pelvic. How is it? Is it aligned? Is it fixed or flexible? If it is fixed, how can we accommodate? We don't want further deformity. And if it is flexible, we provide customized cushions where we give it to use it in the schools or in the home, a study table, and in the wheelchair or specialized chair in the schools. This tiny modification can actually save so many other additional supportive devices. We have seen kids who come in a very late stage where they have already developed pelvic drop, they have scoliosis, they have very poor head control. We have to give multiple orthoses to them, from a seating correction, from TLS or spinal brace, from a head control collar. So before we go to that stage, I think initially itself we address a pelvic drop. It could help many kids, many individual kids. And the last one is assistive technology. There are many devices in the market, and as well as many orthotists, they do customized assistive devices. For example, as you can see in this picture, this is elbow assistive device where it helps individual person to move their elbow, to eat, to brush, to comb hair, to write. This can be fixed in the lap boards of the wheelchair, or if it is kids, they are going to school, it can be fixed into their desk or in the study table. This is very easy for the kids to move around instead of putting excess of energy. And then there are different kinds of devices which is custom made, one of which is universal cuff, which is actually a plastic which is wrapped around your palm, and you can attach multiple devices like pen to write, spoon to eat, brush to brush, and a comb for combing. Multiple things can be used, and this can be made customized by any orthotist. And there are other tools also which can be used to button and unbutton, pull a zipper. This kind of tiny modification can actually help many kids to do things with spending much of energy. And there are some other transfer devices which is easily available in market, and as well as any carpenter also, if you could ask. If you could see in one picture, there is one transfer board which is actually made up of plywood, which can be used to transfer the kid from the wheelchair to the chair, from chair to the bed. And there is something advanced transfer device which we call as hoist, which you could see it on your right side, which can actually help patient to transfer from the bed to wheelchair to the restroom. This is all electrically operated, which is available here in Bangalore too, which is really helpful for kids and for the parents. And the next, this is something can be added into the restrooms. And again, it is available in Flipkart and Amazon, which can really help an individual patient to use a restroom and transfer from chair to commode, and to take bath. If there is something called transfer bath bench, which they can use and take bath. So why I have put up all this assistive technology is that there are many things in the market, and as well as it can be custom made, but then the awareness is so less that many of the parents are not aware of this. This is very tiny things, but then this can make a big change in individual person's day-to-day activities. Thank you so much. Even though I had very small slides, I'm very happy to present it. Thank you for giving me this opportunity.
Thank you, Mahima. I'm going to ask questions for Mahima at the end. We have one last presentation by Miss Victoria. There's a child with the EMD whom she had worked with. So shall we go ahead and take that last presentation?
I think I might have to say that I've had to go and pick my child up from school. So I'm currently in the car, so probably can't present, if that's okay.
All right. I'm so sorry that we missed that talk.
I can save it for you.
Okay. All right. Do we have any questions that any of our speakers can take? There is one question for Dr. Murli. As physios, what parameters can we work on to make post-surgical recovery easier?
So, yeah, see, one of the most important thing is post-surgery would be early mobilization. The tendency is after a major surgery, everybody have a reluctance to mobilize a child. So physiotherapy plays a very vital role. And for preparing them to be mobilized early, we need to give very good chest physio, the respiratory, rehab for the child. So I'm talking about the perioperative period, the initial days. Okay. And from a long-term perspective, part of it, I think the child spends the maximum time with the physiotherapist and the rehab team. There are only short visits to the neurologist, and for surgeons, hardly any visit. After the surgery, it's just, high-bye terms of 6 months, 1 year, and so on. Motivating the child, to answer this, I have seen all the childs are very intelligent. Okay, they don't need coaxing. They already are aware of everything. This has been my personal experience. They come and teach me what I am supposed to do. So motivation was never a problem. So I would say it's respiratory care and mobilization, Ms. Vinita.
Can I add on to that? Sorry, if that's okay.
Yeah, you're the specialist, please.
So being a physio, I think you're right. We do get to see the patients and get to know them. But one of the big things is pain relief. So making sure that there's adequate pain relief and listening to the child as well, because they do often know best, and working with them, I think that gains your trust to them and their trust to you. And agreeing what needs to be done, you do have to sometimes be a bit forceful, and not forceful, but we are sometimes in control and say, right, we have to do this because it's good for you, and explain why, but make it as pain-free and as fun as possible and as natural as possible. And I think most children are just happy to go along with you and do it for you. But yeah, but they always need to say that the surgeon says it's okay.
Thank you. Yeah, I think everybody's sort of wrapping up for today. So thank you to all our speakers for joining us and sharing your experiences. I think that was quite helpful. So I'm going to close off today, but before that, I'm also going to share the summer school flyer. So especially the symposia that are going to take place. So we really look forward to seeing you all at the summer school. I'm just going to share this. Yeah, so I hope you all will register, and we look forward to seeing you all very soon.
Thank you.
Thank you.
Bye.
Thank you. Thank you, Dr. Vinita. Thank you, Dr. Thank you, Ms. Victoria, and Ms. Mahima, and Dr. Jayant.
Thank you. Thank you, ma'am. Thank you, ORDI. We'll close this session with it.